Good morning students, welcome to today's lecture. Today we will be discussing part 2 of the topic Disorders of Development of Teeth and Craniofacial Anomalies. Previous week we had discussed the developmental anomalies related to the number, size and morphology of teeth. In today's learning outcomes, we will be able to identify and describe the disturbances in relation to the structure of teeth. We will also be describing in detail the clinico-pathological aspects of Amelogenesis imperfecta, Dentinogenesis imperfecta and Dentin dysplasia. Before we begin with the topic, let us revise some basic concepts. As you can see here, this is a picture of the enamel organ showing the histogenesis stage of its development. Previous week we had discussed about the morphogenesis stage of the development of tooth bud, wherein any disturbances results in anomalies in relation to the shape, number and size. In the histogenesis of the enamel organ, certain cells undergo specialization into more mature cells, like cells of the inner enamel epithelium undergo maturation into a ameloblast, whereas cells within the dental papilla will form or undergo maturation into odontoblast. The ameloblast is responsible for the secretion of enamel, whereas the odontoblast is responsible for the secretion of dentin. So a normal histogenic development of these cells will result in the normal development of tooth. However, any anomaly affecting during this stage will result in a developmental anomaly which is affecting any of the structure of the teeth. So as we are all aware, teeth is a complex structure made up of different components. All these components are hard tissue, namely enamel, which is forming the bulk of the crown, dentin, which is forming a part of the crown and the bulk of the root, and the cementum, which is covering the outer surface of the root. So developmental disturbances can occur which can affect the structure of enamel, dentin or cementum. Here you can see a normally developed tooth. We can appreciate the surface texture of the tooth, the visual appearance. All these factors appear normal. Also, the physical properties of the tooth will impart its normal strength and resistant to stresses. Any developmental anomaly occurring during the histogenesis stage of the tooth development will result in anomalies which shows pitted or rough surfaces, as seen in this figure, can develop in tooth which are easily worn out and show dense pigmentation, or may result in tooth which are appearing translucent or opalescent. These are examples of various developmental anomalies which are related to a defect in the structure of enamel or dentin. Before we discuss each of the topics, let us revise or understand some key concepts. Most of the developmental defects which are affecting the structure are either hypoplastic or hypomaturation in nature. Hypoplastic basically means there will be a deficiency in the production of matrix. Hypomaturation means there will be hypomineralization. Basically, all the hard tissues in the body are developed in two phases. The initial phase will involve a production of a matrix, which will further undergo mineralization in the second phase, also known as mineralization. So a developmental anomaly may broadly affect the matrix production stage or the mineralization stage. And the anomalies may show variation in terms of its appearance or properties, physical properties, based on which stage is affected. So moving further, in the hypoplastic state, there is only deficiency in matrix production, but the process of mineralization is normal. However, if there is a defect in the hypomaturation stage, the matrix production may be normal, but the process of mineralization is defective. Because of the deficiency in matrix production, the thickness of the structure is generally reduced. However, in hypomaturation form, the thickness of the structure is normal. Because the mineralization process is complete, even though the formed or anomalied tooth is smaller in shape, it will show normal properties. This is because of the normal mineralization occurring in this type of anomalies. However, the hypomaturation form will show reduced physical properties. So the first and common topic we are going to discuss in relation to the developmental anomaly of structure is enamel hypoplasia. Hypoplasia is derived from the Greek term hypos meaning under and plasis meaning formation. So hypoplasia is basically the underdevelopment or incomplete development of a tissue or organ. Enamel hypoplasia therefore means an incomplete development or formation of enamel. So normal enamel is basically formed by the process of amelogenesis, wherein the ameloblasts will form the organic matrix which will undergo mineralization to give rise to the normal enamel. So amelogenesis is basically broadly divided into two stages, the secretory stage whereas the maturation stage. In the secretory stage, a number of enamel proteins are secreted by the ameloblasts, which predominantly includes amelogenins and other enamel proteins like enamelin, tuftelin, etc. It should be remembered that in the secretory stage of amelogenesis, some amount of mineralization does occur. In the maturation stage of amelogenesis, these enamel proteins are broken down and are replaced by calcium hydroxyapatite crystals, which results in more mineralization, giving rise to a mature enamel. So when both these steps are normal, it gives rise to a normal enamel. However, if there is a developmental anomaly which is affecting the secretory stage, it may give rise to enamel hypoplasia. As discussed before, in such form of anomalies, the enamel will generally show reduced thickness, and such enamel generally shows pitted or rough surfaces. On the other hand, if the anomaly occurs during the maturation stage, that is during the mineralization process, it will also give rise to enamel hypoplasia. However, in such cases, the normal enamel thickness is seen. However, because of reduced physical properties, such enamel are quite weak and are easily worn out. Enamel hypoplasia can be caused by broadly local causes as well as general causes. Local causes include local infection in the site of tooth development. Such infection may be because of a previous deciduous tooth which is carious and it is showing periapical infection such that it affects the developing permanent tooth bud. Trauma to the local area of tooth development may also result in enamel hypoplasia. If the developing tooth is exposed to radiations, it can also lead to hypoplastic defects. Certain enamel opacities have been found with no apparent cause. Such causes has been termed as idiopathic. Generalized causes resulting in enamel hypoplasia are basically environmental or systemic causes. Such causes generally affect over a particular time period during the development of tooth, and hence such form of enamel hypoplasias are also sometimes referred to as chronological hypoplasia. The most significant general cause of hypoplastic defects is related to a genetic defect. Under the environmental or systemic causes, further division can be made on the basis of at what stage of the tooth development or at what stage the factors are affecting its development. So broadly, these can be categorized as prenatal, neonatal and postnatal. Prenatal forms generally are due to infections or any maternal disease or due to excess fluoride ions in drinking water. The most common cause for neonatal form of enamel hypoplasia is the hemolytic disease of newborn. It can also be because of deficiency of calcium or premature birth. Postnatal causes generally involve any chronic infection or chronic disease in the infants, nutritional deficiencies which could affect the developmental process of the tooth, or excess fluoride content in the drinking water which results in fluorosis. Genetic factors which result in enamel hypoplasia have a characteristic feature that all the teeth which develop are affected. Hence, they are associated with generalized defects such as ectodermal dysplasia or Down syndrome. The AMELX gene is the most significant gene associated with such defects and has been implicated in Amelogenesis imperfecta. Turner's tooth generally show a characteristic yellowish to brown pigmentation on the enamel, as you can see in the image on the right. Such teeth may also show pitting or irregularity of the surface. The next systemic illness which could cause a developmental anomaly of the teeth is congenital syphilis. The spirochetal organisms may be transmitted from the mother to the child, and such organisms may affect the development of teeth. A variety of developmental anomalies does affect the teeth in congenital syphilis. However, the most common manifestations of congenital syphilis include what is known as the Hutchinson's incisor or the mulberry molars. Hutchinson incisor is also known as screwdriver incisors. Such teeth are characterized by tapering edges of the mesial and distal surface such that the incisal edge is narrower than its cervical counterpart. The incisal edges also show a characteristic central notch. Mulberry molars are also referred to by other terminologies like Fournier's molar, moon molars or bud molars. Mulberry molars are characterized by the presence of small globular masses on the enamel on the occlusal surface of such teeth. The image here shows such globular masses on the surface of the first molar. So, the Hutchinson incisor and mulberry molars are the two common or significant manifestation of congenital syphilis. This is an important point and needs to be remembered. Moving on to the next anomaly that is commonly seen in endemic areas where the fluoride content of drinking water is unusually high. This is what we refer to as dental fluorosis, or otherwise referred to as mottling. This developmental anomaly occurs when the fluoride content of the water is more than 2 parts per million. In such instances, it results in either hypomineralized or hypoplastic enamel. Dental fluorosis can be categorized as mild, moderate or severe. These are based on the amount of fluoride ions in the drinking water. Mild fluorosis is caused when the fluoride content is slightly above 2 parts per million. Such tooth generally show white flecking, white patch or white striations. These are localized areas of opacities or whitening on the surface of teeth. The overall tooth will otherwise look normal. Moderate cases of fluorosis will show slightly increased number of such white patch or white striations along with some focal areas of discolorations. Severe fluorosis, on the other hand, shows dense brownish to dark pigmentations. The surface of such teeth will be characteristically irregular or rough. Another clue to remember during the diagnosis of dental fluorosis is generally such findings are seen in people living in areas which are known to have increased fluoride content in the drinking water. So a thorough history of the patient needs to be taken during this diagnosis. Okay, now moving on to the important topic of today's lecture, Amelogenesis imperfecta. Before we discuss the lesion in detail, let us understand some terms. As we all know, amelogenesis means the formation of enamel, and imperfecta means to something that is faulty. So amelogenesis imperfecta would basically mean an abnormal formation of enamel. Amelogenesis imperfecta is a group of hereditary conditions which are affecting the enamel formation. Broadly, two types of amelogenesis imperfecta are recognized, that is, the hypoplastic form or the hypomineralized, also referred to as hypomaturation form. Amelogenesis imperfecta is related to a genetic defect of the AMELX gene. This anomaly commonly presents as an inherited autosomal dominant trait, which causes defects in the enamel proteins and affects both the deciduous and permanent dentition. It should be remembered that both the dentitions and all the teeth are affected, since this is a genetic defect. So amelogenesis imperfecta is a generalized condition affecting all the teeth. Amelogenesis imperfecta can be broadly categorized as four types: type 1, type 2, type 3 and type 4. The classification is based on the type of genetic inheritance or the defect which caused the type. It is the way it is inherited. This causes the basis of the classification and not the physical characteristics of the tooth. So clinical identification of amelogenesis imperfecta may be difficult. However, certain clinical manifestations may point out to a certain type. As you can see here in this table, type 1 amelogenesis imperfecta is further subcategorized as 7 subtypes ranging from A to G. All these types of amelogenesis imperfecta are hypoplastic in nature. However, they have a different mode of inheritance and shows different clinical features ranging from generalized pitted to localized pitted, diffuse or diffuse rough or diffuse smooth, or at times total absence of formation of enamel. Type 2 form of amelogenesis imperfecta is the hypomaturation type and may show clinical manifestations like diffuse pigmented or snow-capped. The snow-capped form of amelogenesis imperfecta is a typical clinical characteristic and can be identified easily. Type 3 form of amelogenesis imperfecta are basically hypomineralized in nature. The presentation of the anomaly may be diffused. This may be linked to an autosomal dominant or autosomal recessive condition. Type 4 amelogenesis imperfecta may be hypomaturation hypoplastic type or hypoplastic hypomaturation type. It should be noted here that type 4 amelogenesis imperfecta are associated with tooth which are resembling taurodontism. So So this is another important feature which should be remembered because it helps in the identification of the developmental anomaly. So as discussed before, the classification of amelogenesis imperfecta is not based on the clinical characteristics and rather on the mode of inheritance. So a variety of phenotypic variations can be seen in terms of amelogenesis imperfecta. These may vary from pitted surfaces to rough surfaces. Some may present as smooth surfaces with focal areas of defect, the characteristic snow-capped form which shows hypoplastic defects only in the occlusal third of the tooth, or these may show pigmentations as seen in the image D. So it should be remembered that the various forms of amelogenesis imperfecta may show one or more of these phenotypic characteristics. Next, moving on to the Dentinogenesis imperfecta. As discussed previously, Dentinogenesis means formation of dentin, imperfecta means faulty. Hence, Dentinogenesis imperfecta means an abnormal formation of dentin. Dentinogenesis imperfecta is an autosomal dominant condition. It is referred to as the most common genetic dental disorder, showing an incidence of 1 in 6,000 to 1 in 8,000 population. The gene which is related to Dentinogenesis imperfecta has not been identified. It has been thought that there is some genetic defect which occurs in the long arm of chromosome 4. It has also been found that such genetic defect will affect the characteristic protein associated with dentinogenesis, that is the dentin silophosphoprotein. So, in cases of amelogenesis imperfecta, the protein dentin silophosphoprotein, which is related to dentinogenesis, is affected. Since this is a genetic anomaly, it should be remembered that both the primary and the permanent dentition are affected. The teeth have a normal contour and show a characteristic opalescent amber-like appearance as seen in the image. Radiographically, such teeth will show obliteration of the pulp chambers and stunted root development. Because the physical properties of the dentin formed in such anomalies are poor, it leads to early loss of enamel, resulting in marked attrition of teeth, as seen in this image. So the presence of opalescent dentin, obliteration of pulp chambers, and marked attrition of teeth are three characteristic clinical findings associated with dentinogenesis imperfecta. The radiographic observation of such cases is important. As mentioned before, obliteration of pulp chambers and blunt roots are two characteristic findings. If you can see in this OPG, the pulp chambers of all the teeth are hardly visible, and certain teeth shows blunted roots. These are the two characteristic radiographical findings which should be noted while arriving at the diagnosis of dentinogenesis imperfecta. The classification of dentinogenesis imperfecta is also known as Shields classification. Three types of dentinogenesis imperfecta have been identified. These are type 1, type 2 and type 3. Type 1 dentinogenesis imperfecta is always associated with another genetic defect affecting the long bones, that is osteogenesis imperfecta. Type 2 types of Dentinogenesis imperfecta is an isolated condition wherein only the teeth are affected and is not associated with osteogenesis imperfecta. Type 3, also known as the Brandywine type, is a rare condition. It is typically seen in the racial isolate of people in Maryland. Such teeth exhibits multiple pulp exposures and periapical lesions in deciduous dentition. The type 1 and type 2 forms of dentinogenesis imperfecta shows characteristics as described in the previous chapter. That is the presence of an previous slide, that is the presence of opalescent teeth, marked attrition, and radiograph showing obliteration of pulp chambers and stunted root development. However, the type 3, which is commonly seen in deciduous dentition rather than the permanent dentition, displays a characteristic clinical radiographical feature because of which it is also sometimes referred to as shell teeth. So it should be remembered that shell teeth is a manifestation of type 3 dentinogenesis imperfecta, and these are commonly seen in deciduous dentition. The shell teeth shows a very thin layer of dentin overlying a large pulp chamber, such that it appears like a thin shell covering the pulp chamber. So these are the two findings which makes it a shell teeth: the presence of a thin layer of dentin and a large pulp chamber. So that was all about dentinogenesis imperfecta. Another developmental anomaly affecting the structure of dentin is also referred to as dentin dysplasia. The dentin dysplasia is a rare genetic defect and shows more severe manifestations as opposed to dentinogenesis imperfecta. This anomaly is basically further subdivided into two types: type 1 dentin dysplasia, which is also known as radicular dentin dysplasia, or type 2 dentin dysplasia, which is also known as coronal dentin dysplasia. The type 1 dentin dysplasia is characteristically showing a particular feature also known as rootless teeth. This form of dysplasia affects the permanent dentition predominantly. The crown appears normal, however the root development is stunted because of the formation of dysplastic dentin. Dysplastic dentin basically refers to abnormally formed dentin. The pathogenesis of dentin dysplasia is basically related to a defect in Hertwig's root sheath, such that fragments of this root sheath gets incorporated within the dental papilla, resulting in formation of spherified calcified bodies within the dentin. The picture on the right hand side shows a ground section of a tooth of dentin dysplasia. If you can see here, this is the enamel. A thin layer of mantle dentin which appears normal due to the presence of dentinal tubules can be seen. However, further formed dentin shows numerous globular calcified areas. This is what we refer to as dysplastic dentin. Because of this characteristic appearance of globular calcified areas, it is sometimes referred to as lava flowing around boulders appearance. So this is a characteristic clinical appearance of type 1 dentinal dysplasia and should be remembered. Other features associated with dentin dysplasia are that the pulp chamber is obliterated and the roots development are stunted, resulting in premature exfoliation of teeth. The OPG here shows numerous teeth with abnormally stunted root development. This appearance looks similar to a resorbing tooth. However, it should be remembered that this is not because of resorption, it is because of the stunted development of root. Dentinogenesis imperfecta also shows some amount of root formation retardation. However, the amount of stunted root development is as seen in dentin dysplasia. and it is because of this factor that these are also sometimes referred to as rootless teeth. Because of the decreased length of tooth, the teeth are easily susceptible to exfoliation and results in multiple areas of edentulous in the patient. Type 2 dentin dysplasia is also known as coronal dentin dysplasia. That is because here the root development is not affected. The appearance of type 2 dentin dysplasia is similar to that of Dentinogenesis imperfecta type 2. Such teeth may show the opalescent appearance. Type 2 dentin dysplasia generally affects the deciduous dentition, with the permanent teeth generally unaffected. The characteristic radiographic feature associated with type 2 dentin dysplasia is also known as the thistle tube appearance, where you can see an enlarged pulse chamber which continues to a narrow root canal, giving the appearance of a thistle tube. Other radiographic features which can be appreciated in dentin dysplasia include calcifications within the pulpal tissue. Moving on to the next topic, that is regional odontodysplasia. This is also referred to as ghost teeth. This is because of a developmental anomaly, which is because of a genetic defect. However, the gene responsible has not been identified. In regional odontodysplasia, there is abnormalities involving the enamel, dentin, pulp and the dental follicle. It affects both the deciduous and permanent dentition. The maxillary anterior region is the most commonly affected teeth. Other anomalies related to this type of developmental defect gives rise to delayed eruption, shape of the teeth is abnormal, and there is severe hypoplastic hypomineralized defects involving the enamel and dentin. Because all the structure of teeth are affected, there is a loss of distinction between the two structures, that is between enamel and dentin. It should be noted that in normal tooth, the radio opacity of enamel is much more than that of dentin. Because in regional odontodysplasia, all the structure of teeth are affected, there is a difficulty in radiographic delineation between these structures. Hence, it gives rise to a hazy radiographic appearance, because of which it has been referred to as ghost teeth. Moving on to developmental disturbances involving the structure of cementum. Basically, two forms of anomalies are seen. Either there is excess production of cementum, also referred to as hypercementosis, or there is deficiency in production of cementum, referred to as hypocementosis. Hypercementosis is basically because of a periapical inflammation, mechanical stimulation like overloading of tooth may cause increased cementum production. Functionless or unerupted tooth may also result in increased cementum production. Paget's disease is a pathology which is commonly associated with generalized hypercementosis. Hypocementosis, on the other hand, is a rare anomaly and uncommon. It is usually associated with cleidocranial dysplasia or hypophosphatasia. Hypocementosis generally results in premature loss of deciduous or permanent teeth. So this concludes the topic related to developmental anomalies associated with the structure of tooth. The students are advised to revise these topics, especially in terms of Amelogenesis and Dentinogenesis imperfecta and enamel hypoplasia. So we further move on and revise some of these topics that we discussed today. So this will be like a case series. So case number 1. A 25-year-old patient reported with a chief complaint of unusually discolored teeth since birth along with missing tooth in lower front tooth region since 2 years. His history revealed chipped teeth in primary dentition. He also gave family history of similar features present in his mother and maternal uncle. There was no associated systemic bone abnormality. The clinical examination revealed multiple missing teeth and deep caries with pulp involvement in 15, 16, 34, 35, 37, 43 and 44. The generalized color of the teeth present had a opalescent brown hue with worn out incisal and occlusal facets. So here is the image presented by the patient. Please note the characteristic findings as shown in this image. Radiographic examination of the patient also revealed that the tooth had marked constriction at the cervical area, thin to absent enamel, obliterated pulp chambers with short, blunt, conical, malformed roots. So, does this case reflects to Amelogenesis imperfecta, Dentinogenesis imperfecta type 2, Dentin dysplasia type 1, or regional odontodysplasia? Okay, before we give our answer, I want all of you to read the case scenario again and make your correlation before giving the final diagnosis. I will give you 1 minute's time to do the same. Okay, so this case was related to the anomaly Dentinogenesis imperfecta type 2. Okay, let us revise the clinical findings. If you went through the entire clinical findings, you can observe that the patient gave a family history of similar features. So this suggests it is a genetic etiology. Also, the color of the tooth had a characteristic opalescent brown hue. This is a characteristic feature of Dentinogenesis imperfecta. Further, this was confirmed by the presence of thin to absent enamels. It should be remembered that in Dentinogenesis imperfecta, the teeth upon eruption will have a normal thickness but are susceptible to severe attrition. So this could be the reason for thin to absent enamel. Radiographic features showed obliterated pulpal chambers with short, conical, blunt, malformed teeth. These are all features suggestive of Dentinogenesis imperfecta type 2. Is it a congenitally missing tooth? Is it microdontia? Is it Dentinogenesis imperfecta? or is it Hutchinson's incisor? Take a look at the anomaly one more time. You have 1 minute. Okay, so if you take a closer look at this anomaly, you can see that the incisal edge is showing a tapering. That is, the mesial and distal surfaces of the tooth gives rise to a tapered incisal edge. Also, another characteristic finding, that is the central notching on the incisal edge, can be seen here. These two features are suggestive of a Hutchinson's incisor. So this is a Hutchinson's incisor, which is a typical manifestation of congenital syphilis. I request all the students to go through each of the anomaly discussed in the previous lecture as well as today. I request them to download case reports and read each of them so as to enable them to identify such anomalies easily. Please correlate it with the clinical features and radiographic features while doing the same. So, we are still continuing with the lockdown, so I would request everyone to stay at home and stay safe. Please follow all the precautions. Happy learning. Stay safe. Thank you.